Dr. Nardi here, back with another video. Today, we're diving deep into the classification and assessment of abnormal behavior. This is a crucial topic in abnormal psychology because without a way to categorize and understand psychological issues, it would be impossible for researchers to communicate, for clinicians to plan effective treatments, or for us to truly grasp the origins of these disorders. We're going to start by exploring how abnormal behavior patterns are classified, primarily focusing on the DSM system. For centuries, people have tried to classify abnormal behaviors, from Hippocrates' theory of humors to medieval beliefs in demonic possession and natural causes. But the first modern, comprehensive classification model came from the 19th century German physician Emil Kraepelin, and today's most widely used system, the Diagnostic and Statistical Manual of Mental Disorders, or DSM, is largely an extension of his work. The DSM, published by the American Psychiatric Association, was first introduced in 1952, and its latest version, the DSM-5, came out in 2013. While the DSM is widely used in the United States, it's worth noting that the World Health Organization's International Statistical Classification of Diseases and Related Health Problems, or ICD, is the most widely used diagnostic manual globally. So, what are the key features of the DSM system? The DSM classifies abnormal behavior patterns as mental disorders, which involve emotional distress, significantly impaired functioning in areas like work or family, or behavior that puts individuals at risk for suffering, pain, disability, or even death. However, it's important to remember that an expected or culturally appropriate response to a stressful event like grief after a death isn't considered a disorder unless the impairment lasts for an extended period. The DSM system, similar to the medical model, views abnormal behaviors as symptoms of underlying disorders, but it doesn't assume all causes are biological. It acknowledges that many mental disorders have unclear causes and are often best explained by a multifactorial model encompassing biological, psychological, social, and environmental factors. It's also crucial to understand that the DSM classifies the disorders people have, not the people themselves. We refer to an individual with schizophrenia, not a schizophrenic, to avoid the stigmatizing implication that a person's identity is defined by their disorder. The DSM is descriptive, not explanatory. It outlines diagnostic features, but doesn't try to explain their origins. The DSM-5 organized disorders into 20 general categories, including anxiety disorders, schizophrenia spectrum, and other psychotic disorders, and personality disorders, each with specific diagnostic criteria. For example, for generalized anxiety disorder, specific criteria must be met, such as excessive worry for at least 6 months, difficulty controlling worry, and 3 or more associated symptoms like restlessness or muscle tension. Next, let's talk about culture-bound syndromes. These are patterns of abnormal behavior that occur in some cultures but are rare or unknown in others. They often reflect exaggerated forms of common folk superstitions and beliefs within a particular culture. For instance, Taijin-kyofu-sho is an excessive fear of embarrassing or offending others, primarily affecting young Japanese men, reflecting the cultural emphasis on politeness. Dhat syndrome in India involves intense fear over the loss of semen, linked to the belief that semen loss depletes vital energy. Other examples include amok, dissociative episodes of violence in Southeast Asia and Pacific Island cultures, ataque de nervios, emotional distress involving shouting and trembling among Latin American groups, Koro syndrome, fear of genital shrinking found in China and other Asian countries, and Zar, spirit possession in North Africa and the Middle East. Interestingly, Even disorders like anorexia nervosa and dissociative identity disorder, which are well known in the US, are considered culture bound because they are essentially unknown in less developed cultures. Now let's evaluate the DSM system. One of its major strengths is its reliance on specific diagnostic criteria. This provides a common yardstick for different mental health professionals, enhancing consistency. Overall, evidence supports the reliability and validity of many DSM diagnostic categories like anxiety, mood, and substance use disorders. However, questions remain about the validity of some categories, particularly personality disorders. The DSM also faces criticism for being developed mainly by US trained professionals, leading to calls for greater sensitivity to cultural and ethnic factors in diagnostic assessment. While recent versions emphasize weighing cultural factors, clinicians must be careful not to misclassify culturally normative behaviors as abnormal. The DSM is not without its controversies. Critics argue it arbitrarily sets time limits for symptoms, like the 2-week minimum for major depressive disorder. The medical model on which it's based is also challenged, with some clinicians feeling that behavior is too complex to be treated merely as symptoms of underlying disorders, and that the model focuses too much on individual internal factors rather than external influences. There's a significant debate between categorical versus dimensional models of classification. The DSM uses a categorical approach, a yes-no judgment, which critics argue relies on arbitrary symptom counts. Why 5 symptoms for depression, not 4 or 6? This approach also doesn't directly evaluate severity. To address this, the DSM-5 expanded to include a dimensional component, allowing clinicians to rate symptom severity along a scale. Many believe a full dimensional approach, which sees disorders as extreme variations on a continuum of normal traits, would be better. Another critique is that the categorical model doesn't account for common features that cut across different disorders, leading to the development of the transdiagnostic model, which focuses on these interconnections to inform new treatments. Behaviorally oriented psychologists also have their take, viewing the DSM as a convenient labeling system for communication and insurance, rather than a deep analysis of behavior determined by environmental factors. Finally, a significant concern is the stigma and labeling associated with psychiatric diagnoses, leading to prejudice and discrimination, sometimes called sanism. Dr. Thomas Whittaker, a prominent investigator, describes the DSM as the Bible of psychiatry, but acknowledges its shortcomings, including that it often doesn't lead to the identification of a specific pathology with a specific cure. He advocates for dimensional models, like the 5-factor model for personality disorders, which offer a more individualized description of patients. The DSM-5, published in 2013, brought many changes and controversies. There was a proliferation of new mental disorders, a problem dubbed diagnostic inflation. Critics like Alan Francis, former chairperson of the DSM-4 task force, argued that this medicalized expectable life challenges and everyday problems, potentially expanding the number of people labeled with a mental disorder. There were also changes in classification. For instance, Asperger's disorder was reclassified under the broader autism spectrum disorder, and PTSD moved to a new category. Changes in diagnostic criteria for specific disorders, such as autism spectrum disorder, also sparked debate about their impact on diagnoses. Some criticisms even targeted the process of development, citing secrecy and insufficient empirical research. Despite these debates, one generally well-received change in DSM-5 was its greater emphasis on dimensional assessment for severity. The DSM, despite its years of debate, editing, and review, remains a work in progress. Moving on from classification, let's turn to standards of assessment. Just as diagnostic systems must be reliable and valid, so too must our methods of assessment. Reliability refers to the consistency of a measurement. We assess reliability in several ways. Internal consistency, whether different parts of the test yield consistent results. Test-retest reliability, whether the test yields similar results on separate occasions. And inter-rater reliability, whether different raters show a high level of agreement in their ratings. Validity means the assessment instrument measures what it intends to measure. If a depression measure actually assessed anxiety, it would lead to incorrect diagnoses. Key types of validity include content validity, the degree to which a test content represents the behaviors associated with the trait being measured. Criterion validity, the degree to which a test correlates with an independent external standard, including predictive validity, sensitivity, and specificity. And construct validity, the degree to which a test aligns with the theoretical model of the underlying trait it purports to measure. It's interesting to note that a psychological test can be highly reliable, but also invalid. 19th century phrenologists who believed personality was determined by skull bumps could reliably measure those bumps, but these measurements were invalid for assessing psychological traits. Now let's explore the methods of assessment clinicians use. Currently, we don't have laboratory blood tests or brain scans that can reliably diagnose psychological disorders like depression or schizophrenia. Instead, we rely on a comprehensive assessment process that includes interviews, psychological testing, self-report questionnaires, behavioral measures, and physiological measures. This gives clinicians a broad understanding of a client's problems and helps recommend appropriate treatment. The clinical interview is the most widely used assessment method, often the first face-to-face contact. During an interview, the clinician gathers extensive information, typically covering identifying data, a description of the presenting problem, psychosocial history, medical and psychiatric history, and current medical problems or medication. The interviewer also pays attention to nonverbal behavior, apparent mood, focus, clarity of thought, and orientation to form judgments about the client's mental state. There are three main types of clinical interviews. Unstructured interviews, which offer spontaneity but lack standardization. Semi-structured interviews, which follow a general outline with flexibility. And structured interviews, which use a preset series of questions in a specific order and offer the highest reliability, such as the structured clinical interview for the DSM. Computerized interviews are also becoming more common, offering efficiency and sometimes greater disclosure, but lacking the human touch. Psychological tests are structured, standardized methods to evaluate stable traits like intelligence and personality. Intelligence tests, such as the Wechsler Adult Intelligence Scale, help diagnose intellectual disability, evaluate impairments, and profile strengths and weaknesses. Personality tests include objective tests like the MMPI-2 and Millin Clinical Multi-Axial Inventory, and projective tests like the Rorschach Inkblot test and thematic apperception test. Objective tests are structured and empirically validated, while projective tests present ambiguous stimuli to reveal unconscious motives, though their validity is debated. Neuropsychological assessment uses tests like the Bender Gestalt and Halstead-Wrighton battery to detect brain damage or impairment. Behavioral assessment focuses on observable behavior in context, using functional analysis, direct observation, self-monitoring, analog measures, and rating scales. Cognitive assessment measures dysfunctional thoughts and beliefs with tools like the Automatic Thoughts Questionnaire and Dysfunctional Attitudes Scale. Physiological measurement examines biological responses linked to anxiety and other disorders, such as galvanic skin response electromyography, EEG, CT scans, PET scans, and MRI or fMRI. Finally, sociocultural factors must always be considered in assessment. Accurate translations, cultural norms, and language preferences are essential to avoid bias and misdiagnosis. For example, the Beck Depression Inventory and MMPI-2 have shown cross-cultural validity, but clinicians must be careful not to label cultural differences as pathology. In summary, classifying and assessing abnormal behavior is a complex, evolving field. We've explored the DSM system, its features, its controversies, and the crucial role of cultural context. We've also delved into the standards of assessment, reliability, and validity, and the diverse methods clinicians use, from interviews and psychological tests to neuropsychological, behavioral, cognitive, and physiological measures, including brain imaging. Each method offers unique insights, and often a combination provides the most comprehensive understanding of psychological functioning. While challenges remain, particularly in achieving diagnostic clarity and overcoming stigma, the field continues to advance our understanding and treatment of abnormal behavior.